Hello and welcome to the Do Something Admirable podcast. My name is Alex. My patients call me Dr. Watson, or also Alex. This podcast name is a play on both the name of our medical practice, Admire Medical, and the previously unspoken mission of the practice. We help our patients rise above the waves after life-changing events or reach new depths exploring their passions. But this show is for anyone looking to be inspired and then inspire others to do something admirable.
Hey, this is Alex for the Do Something Admirable podcast. We have Lauren here. I thought we'd record this one. We're about to go over her labs and thought that it could be an excellent teaching point. So we're working with two cameras. If I'm looking over there, just in case you know. All right.
And if this thing moves, it's Desmond in my lab.
We have a Desmond. All right. So Lauren just did some initial blood work, kind of a once over on the metabolic side of things. So we wanted to make sure that everything looks good and that we're, doing the best medicine for ourselves as well.
Gotta practice what we preach.
And the interesting thing here is she has what looks like bad lab results, but are actually pretty indicative of the opposite. A very healthy lifestyle that shows the nuance when it comes to some of these tests here. Basically just proves how unnecessarily complicated some of this biology is. Best example here is her cholesterol panel. So I'll read the numbers first and then explain to Lauren and kind of as a lesson that way. Total cholesterol of 253. And, the normal range for this lab is up to 200, but, 253 is objectively high. With LDL-C, it's the quote-unquote bad one, as 143, given, no other information, if I had to pick a number that we're shooting for, it's under 100, ideally even lower than that. So 143, when I first saw this, I'm like, oh man, that's actually kind of bad. We also got another, you're out of order, couple other points too. Of course, there's an HDL-C, so the quote-unquote good one. Triglycerides, we're always checking that too. And then an APO B. What APO B is, thank you. APO B, also known as LDLP, that's a number of particles carrying the quote-unquote bad cholesterol, the LDL-C. The point there is that, you can use either data point by itself. LDL-C is what we've used forever. And the reason why is that correlated pretty well with health issues, and blood vessel diseases like heart attacks, strokes, that kind of thing. But we got better ways of testing the APO B, and really that's actually the main mediator of the risk here. And the reason why is essentially when you have any sort of heart disease, blood vessel disease, you have injury to blood vessel walls. And what happens is the particle busts through the wall, gets stuck there, oxidizes. Antioxidants does the opposite of that. It oxidizes, which is kind of pro-inflammatory. And so you have all the immune cells come in, and it builds this plaque up, which then narrows the blood vessel wall. That by itself is bad. But if when the plaque ruptures, then it opens up in clots, then that's how you can get an acute heart attack or a stroke locally. All that preamble is relevant here because when you look at a very high LDL-C, yet a very normal APO B, well, what are we actually measuring here? A high LDL-C is measuring the amount of cholesterol on those APO B particles. So if you have a high amount of cholesterol there, but moderate number of particles, that's saying they have a few big fluffy particles carrying all that LDL cholesterol, trafficking that stuff around for utilization in the body. And by doing that, they're big fluffy particles. They have a tougher time going through the wall, and there's fewer of them. So you're going to have fewer quote unquote shots on goal, opportunities for the cholesterol particle to go into the artery wall and get stuck and cause problems. So what looks like a bad test result is actually a great one. And going back to the total cholesterol being 253, the reason why I hate that one is because it factors in stuff like that and includes, the quote unquote good cholesterol and the LDL-C as two factors in the total cholesterol. So if you have high HDL-C, which is a good thing, all else held equal, and high LDL-C, which in this case is not necessarily bad, not ideal, but it's okay in this case. You add them together, all of a sudden your total cholesterol is, off the charts, but it's actually not a big deal. Which brings us to her HDLC, which is, I believe, the highest I've ever seen. It is 100. I've never seen a triple digit HDL cholesterol, which is reflective of a lot of things. Without getting too deep into it, really, it's part of that transport of LDL transport of cholesterol and all the other stuff that those particles carry. So for someone who's got a healthy diet, exercises a lot, those particles are carrying stuff to be burned as energy in a lot of cases. Or it's reverse transport, bringing stuff back to the liver from other cells and everything. Long story short, great, So in this case, again, that super high total cholesterol is relatively meaningless. The other data points here that we looked at, so the triglycerides. Triglycerides used to not be as high profile as they become, justifiably. The reason what that is it's literally just blood fat. And it's, again, measuring on the particles that are carrying them. So things like LDL, the APO B carry, I believe, some amount of triglycerides, and there are other particles that carry more of it, and yada, yada, yada. When you have metabolic syndrome, so the combination of obesity, fatty liver disease, all the stuff that comes with that, blood pressure, cholesterol, all the charts, all that stuff, and insulin resistance here with the diabetes, that tends to bring up the triglycerides because of mismanagement of these things. But also there's a reverse picture of the causality here, where high triglycerides, they mess with the liver and then cause an insulin resistance. So there's a bidirectional relationship between diabetes and triglycerides, and now we're realizing it's a big deal, because if you manage the triglycerides well, you then can improve insulin resistance. They actually directly impact the ability of the receptor to use insulin to bring blood sugar in. So if you have all these fatty acids messing that up, that's where some of this insulin resistance comes from in the context of high triglycerides. Very relevant. It's also relevant because we have ways of treating that directly. Fish oil is a pretty well-known way of bringing down triglycerides. Also just improving your metabolic health. So if you're someone who's got insulin resistance, trimming back the carbs, it's a pretty straightforward way of doing that. And some of the medications that we use to improve that too will then improve triglyceride levels. Also improve fatty liver disease. So things that kind of go along with insulin resistance, those factors tend to improve fatty liver disease. There are medications that can target it pretty well now. Semaglutide and tirzepatide being ones of them. So it's becoming easier and easier, relatively, to treat this stuff that used to be really big deals. But you only know if you have an issue if you do the tests. So that's why it's important to know your numbers. All right, so we also dove into that hemoglobin A1C. It's a good screening test for diabetes. It's not perfect. What it's looking at is the red blood cells, how much of them have, glycosylated, so sugar attached to it, basically. And in this case, essentially, it's the longer, red blood cells' average life is 3 months. So over those 3 months, how much sugar is exposed to? If it's exposed to more sugar, then it's going to be higher A1C because more of the red blood cells have been tagged with the sugars. But just by understanding that, you also can realize how it can be artificially high or low. If you have shorter life of red blood cells, someone who's got a hemolytic disease where they don't last as long, or sickle cell, or thalassemia, one of those exotic diseases, then your A1C is less reliable. Or if yours lasts longer, then your A1C will be higher, but it doesn't actually mean you have diabetes. So that's why A1C is not a perfect test, but it's a pretty good one.
So I'm good at 4.9%.
You are stellar at 4.9%. You're better than me. So, yeah. So, again, 4.9% is a great place to be. The cutoffs for insulin resistance is about 5.7 in most cases. The lower the better, really. Again, mine's higher than that, but it's probably because of my late night ice cream. Thyroid hormones, we check these a lot. People scream at TSH. In most cases, screening with TSH is fine by itself. And if you have had any sort of brain surgery or any sort of brain issues, strokes, traumatic brain injuries, then TSH is not as reliable. You want to check a T4 or T3. That is, the actual thyroid hormones that are doing stuff. But if your TSH is high, that means your active thyroid hormones are low, and your brain's trying to fix that. But if you have brain surgery and stuff, then that pathway might be a little abnormal, and so not reliable as an indicator of what your thyroid levels are. So
Nice.
it's less volatile. That's why we check it. All right. your other numbers all look fine. I will highlight a few important ones. I was looking at MCV because you infer, potentially iron deficiency if the number is too low. So under 80 usually is the cutoff for that. It can imply B12 or folic acid deficiency. It is too high. My cutoff of starting to look at this is actually around 95. So if it was 94, might need a little more folic acid or B12. Not a big deal. The other situations is, MTHFR has become all the rage these days. If your body's unable to appropriately utilize folic acid and B12, it's like you don't have enough. So if you have, I don't know how to go on my soapbox with MTHFR, it is a spectrum. It is not a good or bad. So some people will say, I have a mutation. Oh my God, what do I do about this stuff? A lot of cases actually isn't meaningful. We test that by looking at two things. Again, the MCV is one dirty test for that, nice and easy. Or you can look at a homocysteine, which is kind of the other end of the spectrum. What else can be affected by abnormal methylation pattern? That's what MTHFR does. It has a methyl group to certain compounds to make them active, effectively. So in those cases, if both are fine, then I can tell you without even looking at MTHFR status, is irrelevant. If it is, slightly less functioning, it's not clinically meaningful. Don't worry about it. I've had this conversation a lot recently. Okie dokie. So moving on here, we look at hemoglobin, of course. Some people are hematocrit people. Some people are hemoglobin people. I'm just used to the hemoglobin. And I see your hematocrit. Where's your hemoglobin? Well, either way, it's fine. So, not super meaningful here. Low hemoglobin is not necessarily abnormal for, women of childbearing age, just because we lose a lot of blood monthly. For men without a known cause of low hemoglobin, then we worry about, okay, what causes you to lose blood and not know it? Oftentimes it's GI bleeding, so blood in your stool. If you're of a certain age, then it's a concern for colon cancer, not necessarily. Other causes, of course, are iron deficiency. So if you have an odd diet that can bring down your hemoglobin, I look at this in context with that MCV to point in a direction. So if your hemoglobin is low and your MCV is low, you have an iron deficiency. Again, what are main causes of iron deficiency? Diet, absorption, or loss. So either you're not eating enough because you have a restricted diet, you're not absorbing well, so you have some sort of GI issue, whether it be Crohn's, celiac, something like that, or you're losing it, bleeding somewhere. Again, check your stool. If your hemoglobin is low and your MCD is high, then I'm looking at that folic acid or B12. Oh, there's hemoglobin. Yeah, so it's 13.7. So with your MCD of 94, but your hemoglobin being normal, then you may be a smidge low on B12 or folic acid, but it's not really affecting you too much right now. Not substantially, but if it's chronically deficient, then they can cause horrible problems. So you might want to supplement there.
Okay.
Excuse me. It's dry in my office. Other things that we order is CMP. So a CMP is like a BMP, which is your electrolytes in kidneys and stuff. It adds on some of the quote unquote liver enzymes. Liver enzymes is a bit of a misnomer, but they are enzymes in your liver. And we use them to just infer status of the liver. So the cutoffs are based on population norms. Well, populations aren't super healthy these days, so we have our own kind of preferred numbers. The cutoff here is 48 for an ALT. Most of them is 40. I like it around 20 or below. Here's 25. That's perfectly fine. You also look at the ratio typically between the ALT and the AST. If the ALT is substantially higher than the AST, that again points to more likely to have a liver issue. Oftentimes these days it's fatty liver from non-alcoholic causes or alcoholic causes. So you can play a little detective here. If your ALT is high and your MCV is high, then it's like, okay, you're drinking too much. That's depleting your folic acid, amongst other things. Or again, usually it's just fatty liver. And if it's bad enough to be reflected in the liver enzymes, then that's meaningful. There's plenty of fatty liver that's still relevant that doesn't even elevate liver enzymes yet, and then you gotta worry about it a little bit. So, in this case, again, they're fine. Albumin by itself when you're not sick or inflamed anyway, is a decent marker for nutritional status on the protein side. It's a longer circulating protein produced by the liver. So if you have enough protein, your albumin should be sufficient. If you are sick, it can make that abnormal. If you don't have enough protein, it'll be abnormal. So usually, unless I have you're obviously healthy, I wouldn't get an inflammatory test, but in many cases, if I'm getting an albumin to look for this kind of thing, or a pre-albumin, which is another form of this, I'm also getting other tests to check inflammation. So like a CRP or a SEBRI. If those are high and then albumin is abnormal, then we have another reason for it. If I don't have the albumin, I can look at calcium, because calcium is bound to albumin. So if your calcium's high, it's usually not high calcium, it's usually low albumin.
So what's optimal for?
Wait, sorry, I misspoke there. It's low albumin because you're carrying less of around there. That's
So I see. Okay.
What's your question?
What's like optimal for albumin numbers?
I mean, it's based on the range on the lab. Typically, 4s is a spot where I want to be. If it's like way too high, this is my wheelhouse. But too much protein usually is indicative of, I believe, liver disease. We maybe spilling it out when it shouldn't be. It's elevating the amount in the blood, but your total body amount isn't actually higher. I should know this stuff. It's been a while since I've been on my boards. We'll move on. We'll cut this out too. Other factors too, that creatinine. So creatinine is our cheap and easy test of kidney function. It is not perfect. It can be skewed by a lot of things, muscle mass being a big one of them, especially if you take creatine. So creatine by itself does not raise creatinine typically. There's a lot of research on this. However, creatine is someone who works out and has been on it for a while and has built muscle and stores more creatine, your creatinine should go up. So my creatinine looks like I have kidney disease. I do not. I just take a lot of creatine and work out a lot. Lauren too. So your creatinine of 0.8 is relatively high for someone your age and gender. Not super high, but it's because you're active and strength trained and should take creatine if you don't.
I do. Oh, I do.
Good. Read the blog. There's a lot I've wrote about creatine because it is one of those things that should literally go and drink water, and can't say enough good stuff about it. Anyway, I'll look at electrolytes. If I have reason to be worried about them, then I'll be more paying attention to them. In your case, I had no reason to really worry, and they're fine. But if someone is, dehydrated, I look at sodium to see if they're dehydrated in the context of an elevated creatinine. They helps provide context. If sodium is too low, then I worry about, okay, is that from the antidepressant side effects or other medication side effects or heart failure where you're hanging on to too much water and diluting that sodium down? Those are the things we look at for sodium. It's very complex. A lot of medical people get tripped up on it, so we do not expect patients to know the nuance of electrolyte interpretation in the context of disease. But those are from the things I'm thinking about when I see sodium levels. And the fasting glucose is the last thing we'll comment on here because I don't like it usually, especially in the morning. The fasting glucose is useful in the afternoon when you're actually fasting and not influenced by stress or by bad sleep, which can raise your cortisol and make your fasting glucose look abnormal and make it look like you have, insulin resistance. So for me, my fasting glucose, I've checked it a bunch of times, and sometimes it's, in the age of 90s. Other times it'll be a teen, 100, like 1/10. And that usually follows after a night I was on call as a resident or had a, bad night's sleep for whatever reason, or I'm stressed out or don't like getting blood drawn. All those reasons can elevate your fasting glucose, make it look like you have insulin resistance, and actually everything's fine. So if I have nothing else to look at, basically if it's normal, that is a useful data point. You're 84, that's fantastic. If it is abnormal, I don't get too worried about if we have an A1C that's normal or someone who very obviously does not have metabolic disease. Any questions?
No. Besides the fact that I'm perfect, right? Based on my blood work.
Oh, good. Hammer belt. Just to prove a point.
Wait, actually, I have one question because I know my people who know me would want to ask this question. Is my HDL or LDL really high because I eat eggs every day?
Strong it. We'll cut all that out so that we ask to go there.
Okay. Is my HDL or LDL high because I eat eggs every single day?
Not at all. So that is a common point of debate. Dietary cholesterol does not actually influence cholesterol whatsoever. Saturated fat, oddly enough, does, which is why foods that are high in saturated fat, that are often high in cholesterol, may actually raise your LDL cholesterol. So, yeah, I mean, eggs do have saturated fat in them, but not a profound amount. Really, the link between saturated fat is closer because you have a really good understanding of why. To make it brief, it might make this a separate spin-off clip. The reason why your dietary cholesterol does not immediately get translated onto those APO B particles and carry around all that stuff. It's usually utilized for purposes and everything like that. But when you are, so your blood level of cholesterol is managed closely by the amount of receptors for LDL cholesterol or APO B that your liver is expressing. Okay. So if you express more receptors, then your cholesterol will be lower because then it's taken in to the liver, not circulating in the blood. All things are good. However, there are many diseases that we know that impact the expression of those receptors. So one of the medications that we use now, they're called PCSK9 inhibitors, and what they're doing is they're inhibiting an enzyme that breaks down those receptors. So by inhibiting an inhibitor, you then raise the receptor expression and lower cholesterol. Older medication being statins. Okay, so here's where it gets really fun. Statins, we initially thought they worked because they literally stop the production of cholesterol. So they block an enzyme called HMG-CoA reductase, and what that does is it's the way that your body takes precursor molecules, I'm not going to go into now, and build it into cholesterol. So when you take a statin, you block that process, and then you say, okay, well, obviously then my cholesterol is going to be lower. What actually ends up happening is your liver goes, oh crap, I don't have cholesterol to do stuff. I'll get to that later, what that is, but it does. And so it expresses more receptors. So really the cholesterol lowering effect of statins is because of the expression of receptors in response to low levels of cholesterol in the liver. So that is why they work that way. Also, you cannot make your cholesterol too low. It is not a thing. We have ways of knowing this because people with, errors in PCSK9 who have very low levels of cholesterol for their entire lives don't have any negative effects. They just don't have heart disease. Kind of a perfect proven point here. They don't have any sort of neurologic disease due to a lack of cholesterol and the things that people always say is going to happen with statins. That doesn't seem to happen. We have so much data on the safety of statins. We have data demonstrating that they reduce risk of dementia and things like that because blood vessel disease is obviously causal in the pathway of dementia. And if you protect blood vessels, you're not going to have as much, kindling for the fire of dementia. And the other piece too is they're also a little anti-inflammatory. So by being anti-inflammatory, going back to the plaque that happens when the particle breaks through the artery wall, you have less inflammation in the artery wall, well, then you have less development of that plaque. So they have a lot of reasons to, promote good health of blood vessels, but they can actually cause a little bit of insulin resistance to worsen. That is meaningful, and they have known effects on muscle, aching, and in some cases severe muscle damage. The incidence of it being quote unquote real, we know this by what we call placebo-adjusted, data points here. So we see how people have side effects on the placebo, subtract that out from the drug, and the difference is the actual number is very low. I believe it's less than 1%. So most people that have muscle soreness from statins have it because they think they're going to have it, unfortunately. The other piece here too is, go back to this process here. I only mentioned the whole thing with insulin resistance and all that because there's actually medication in development right now that I talk about all the time because I'm super excited about it. It is called obicetrapib, and the beauty of this one is it is working on a pathway that we knew would be good, but the molecules were too similar to hormone in our kidneys and a raised blood pressure when we tried to make something like this back in the day. Well, they worked that problem out. So now these studies on this medication are showing phenomenal lowering of cholesterol in ways that we didn't ever see from statins and those PCSK9 inhibitors. The cool part is they actually improve insulin resistance too, which is fantastic. So not only do they not worsen it like statins do, they actually dramatically improve A1C and all that stuff. And the other really cool part too is recently a study came out demonstrating that for people who had the opposite of that PCSK9 issue, they had damage in the LDL receptor, so their cholesterol sky high, familial hypercholesterolemia is what it's called. They took patients with that disorder, brought their cholesterol down to 100. Then they gave half of them this medication. In 1 year, it still reduced their risk of major adverse cardiac events, so heart attacks and strokes, by, it's like 20 or 30%, something ridiculous, in a year for people who already were, quote unquote, at goal of their cholesterol. That is astounding. But that is a result that says there's something else going on here with the molecule that we just don't understand yet. It's that cool. And it seems to be very well tolerated too. And it's oral, so it's not an injection like the PCSK9 inhibitors are. So for so many reasons, I tell the story of my patients who are worried about statins and can't afford a PCSK9 inhibitor and their insurance doesn't cover it. I say, just be patient. Take statins if you can tolerate it. We have better things coming. And there are already other things too, like ezetimibe and bempedoic acid and things like that too. But I kind of leave those for the cardiologists. The last piece here too. Oh yeah, saturated fat, where we started. Okay, now that we've gone through the other aspects of the biochemistry, saturated fat is relevant because what your liver does to express those receptors is it's checking the fluidity of its membranes. So it uses an internal, somehow it knows how fluid the membranes are, because cholesterol, that's what it does for cell membranes, is the fluidity. If they're too stiff, put more cholesterol in, membranes become more fluid, good with the cell, whatever. The saturated fat has a similar effect on membranes. It makes them more fluid, like cholesterol. Well, if the membrane's fluid enough, then you're not going to express the receptor, bring more cholesterol in to do that. So because of that, when you have saturated fat, you have less expression of that LDL receptor, you have higher cholesterol. That's why. And so dietary cholesterol doesn't do that. Saturated fat does. Foods that have high saturated fat often have high dietary cholesterol. That's where the confusion probably came from.
Yeah.
So eat your eggs. The protein and the B vitamins and choline and all that fun stuff is way better for you and do more than a little negative impact of whatever saturated fat's in there.
You heard it here, folks. Eat your eggs.
And some people are more sensitive to that stuff than others too. So some people are very sensitive to saturated fat affecting their cholesterol. I actually think we're kind of those people in our family. Others don't seem to be the case. And you see this most in ketogenic diets. People that can tolerate eating whatever sort of fat, whatever sources of fat. Others that need to really keep the saturated fat low because it cranks up their numbers. Any other questions?
Nope.
There will be a test on this. I hope you listened closely. All right. Thank you for listening. Really appreciate it. If you found this helpful at all, please like, share. Let's pick one. Like this one. I'll ask you to share next time. Have a good night.